The following podcast is part of a certified educational activity titled Determining Which Patients Will Benefit from GLP-1 RAs, Applying Guidelines and Evidence to Individualize Treatment Decisions in T2DM. Access the entire activity and complete the post-test at peerview.com/KMJ860. Downloadable resources are also available.
Hello, this is Dr. Vinita Arota from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this infographic-based educational activity that is designed to help you identify which patients might benefit from GLP-1 receptor agonists to better individualize treatment of their type 2 diabetes. GLP-1 receptor agonists have emerged as a highly effective treatment class for type 2 diabetes, targeting many of the underlying defects in type 2 diabetes. Let's conceptualize the effects of GLP-1 receptor agonists in 3 dimensions to better appreciate how and why these medications work as they do for patients with type 2 diabetes.
GLP-1 receptors are found in many tissues, including the brain, heart, lungs, pancreas, stomach, duodenum, and kidneys. Consequently, GLP-1 receptor activation has many glycemic and non-glycemic effects. In the brain, GLP-1 receptor activation suppresses appetite, facilitating weight loss. In the heart and vasculature, GLP-1 receptor activation decreases atherosclerosis. In the lungs, GLP-1 receptor activation may reduce chronic inflammation. In the pancreas, GLP-1 receptor activation stimulates insulin secretion and suppresses glucagon, but only if glucose levels are elevated. This means that GLP-1 RAs have an intrinsically low risk of hypoglycemia. In the GI tract, GLP-1 receptor activation slows gastric emptying and reduces intestinal motility. These effects slow glucose absorption, limiting postprandial glucose excursions. Finally, in the kidneys, GLP-1 receptor activation increases diuresis and natriuresis and reduces albuminuria.
Currently, there are 6 approved GLP-1 receptor agonists available for the treatment of type 2 diabetes. We can classify them as exendin 4-based GLP-1 receptor agonists, and these include exenatide twice daily, exenatide once weekly, or lixisenatide, or as GLP-1-based GLP-1 receptor agonists, and these are liraglutide, given once daily, dulaglutide, given once weekly, or semaglutide, given as a once-weekly injection or as a daily oral tablet. When we look at the current guidelines, GLP-1 receptor agonists are prioritized in several areas. In patients at high risk or established atherosclerotic cardiovascular disease, independent of A1C levels or target, or as an option in patients with chronic kidney disease, particularly since chronic kidney disease increases cardiovascular risk, also to support weight loss, to minimize hypoglycemia, and as the preferred alternative to insulin therapy when a high-efficacy agent is needed. Multiple cardiovascular outcomes trials have been completed with GLP-1 receptor agonists, showing consistency in the class, particularly with longer-acting GLP-1 receptor agonists. Here we see a significant 26% reduction in major adverse cardiovascular events with subcutaneous semaglutide in the SUSTAIN-6 trial, a 13% and 12% reduction with liraglutide in LEADER and dulaglutide in the REWIND trials, respectively. One of the components of the major cardiovascular outcomes composite is cardiovascular death. Here we see reductions in the hazard ratio for cardiovascular death with both oral semaglutide and with liraglutide, though one must remember that differences in trial population and trial length may account for some of the apparent differences shown here. The cardiovascular outcome data directly impact the approved indications for use in the prescribing information of these medications. All GLP-1 receptor agonists are approved for use for treatment of type 2 diabetes. Dulaglutide, liraglutide, and subcutaneous semaglutide are all approved to reduce major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. And dulaglutide is also approved to reduce risk of major adverse cardiovascular events in type 2 diabetes with multiple cardiovascular risk factors. In addition, a large pediatric study resulted in the approval of liraglutide for use in children aged 10 years and older. The cardiovascular outcomes trials also reported on pre-specified renal endpoints, with again the longer-acting GLP-1 receptor agonists demonstrating improvements in composite renal outcomes, including and largely due to reductions in albuminuria. Moreover, there are suitable GLP-1 receptor agonists for use across the full kidney function spectrum. Liraglutide, dulaglutide, and semaglutide do not have any limits of use by renal function. For patients with renal impairment, severe gastrointestinal intolerability and changes in volume status should prompt closer monitoring of renal status. Type 2 diabetes is a multifactorial disease process, and thus appropriately, we have multiple goals for our patients. GLP-1 receptor agonists address many of our clinical care goals, including helping patients achieve glycemic treatment targets through their high efficacy and low risk of hypoglycemia as glucose-dependent agents. Importantly, they suppress appetite, promoting and supporting weight loss. They have been shown to be cardioprotective, reducing risks of cardiovascular disease in the cardiovascular outcomes trials, and are versatile for use in patients with chronic kidney disease and other high-risk populations. Let's look more closely at the practical aspects of how to individualize treatment with GLP-1 receptor agonists in clinical practice. In this presentation, we'll review dosing and administration, glycemic effects, effects on weight, hypoglycemia risks, and other safety considerations. We'll also hear about the experiences from a patient who is currently using a GLP-1 receptor agonist. Exenatide twice daily is given within the hour of morning and evening meals, with a pronounced effect on postprandial blood sugars. Lixisenatide, also with a strong effect on postprandial glucose excursions, is given within an hour of the first meal of the day. Liraglutide, a longer-acting GLP-1 receptor agonist, can be given any time of day. For oral semaglutide, as this is the first oral GLP-1 receptor agonist and peptide, there are a few clinical pointers to optimize its absorption and its effect. First, we advise patients to take oral semaglutide at least 30 minutes before first food, beverage, or other oral medication, and to take it with up to 4 ounces of water, from a sip to half a cup, and to swallow the tablets whole without crushing them. Like the injectable GLP-1 receptor agonists, oral semaglutide is started at an initial starting dose, then titrated to the effective treatment doses in order to optimize gastrointestinal tolerability. The weekly GLP-1 receptor agonists are self-administered once a week and, as long-acting agents, can be given at any time of day. Most of the GLP-1 receptor agonists have an initial starting dose to minimize gastrointestinal side effects, followed by titration to maintenance treatment doses. With GLP-1 receptor agonists, we generally see a dose-dependent effect with higher glycemic and weight effect at the higher maintenance doses. On a practical level, currently both weekly exenatide and dulaglutide are administered with an autoinjector, such that the needle is not seen by the patient. And semaglutide is available either as a weekly injection or as daily oral therapy. Let's hear about the GLP-1 receptor agonist journey from a patient perspective.
I want to say at least 10 years ago, and I was diagnosed because of my weight, number one. And number two, it was the summertime with the kids in the camp. And of course, McDonald's always been our friend. So not only did I have a banana milkshake, I also had a chocolate milkshake. And then I had the other stuff the kids brought in. But lo and behold, we was having a health fair that particular day. And everybody was getting checked for everything. But as me being the site director, of course, I was too busy. I didn't need to get checked. But at the end, they checked me, and they found out that my sugar was almost 500. And I'm looking at them like, and everybody's running around panically, and I'm still working with the kids, and I'm saying, well, what's wrong with them? I end up going to the hospital, and instantly, they gave me insulin. maybe 2.5 years. Will be my 3rd year. The GLP, although it's still a needle, it's a different type of needle because you can't hardly feel it. You don't know it's going on really. You just know you have to take it. It's not as invasive as when I was taking my insulin, and it just, as a matter of fact, I look forward to that. It's definitely every Sunday before Monday start. So it's in the refrigerator. This is what you have to do. So right before I go to church or even virtual church, before breakfast, this is what I take, and then that's my routine.
Patients like Mrs. Schultz remind us of the importance of stepping back, individualizing, and refining therapy around patient-centered goals. A recent comprehensive network meta-analysis evaluating the comparative effectiveness of glucose-lowering drugs for the treatment of type 2 diabetes highlights the high glycemic efficacy of the GLP-1 receptor agonist class relative to the other classes. This high efficacy translates to high achievement of treatment goals, as seen in many of the head-to-head active comparator studies. Here we see the efficacy in drug-naive patients. And here we see the same high efficacy of GLP-1 receptor agonists when added to metformin therapy, with again higher glycemic efficacy seen with the longer-acting GLP-1 receptor agonists, semaglutide, dulaglutide, extended-release exenatide, and liraglutide. The effect of exenatide twice daily and lixisenatide on overall A1C is consistent with their mechanism of action in primarily targeting postprandial glucoses. Avoiding and minimizing hypoglycemia is also an important care goal. GLP-1 receptor agonists only stimulate insulin secretion and suppress glucagon when glucoses are elevated, resulting in an intrinsically low risk of hypoglycemia. However, since insulin and sulfonylureas have incessant glucose-lowering action, using GLP-1 receptor agonists in combination with insulin or sulfonylureas may increase the risk of hypoglycemia, and thus one should consider reducing or weaning down the dose of insulin and sulfonylureas when initiating GLP-1 receptor agonist therapy. What is the range of weight loss we are seeing with GLP-1 receptor agonists? With the earlier GLP-1 receptor agonists, we saw mean weight loss of around 2 to 3 kilograms in the clinical trials. With newer GLP-1 receptor agonists, such as semaglutide and high-dose dulaglutide, we are now seeing higher mean weight loss on the order of around 4 to 6 kilograms, depending on the clinical trial. So let's hear again from Mrs. Schultz.
Once I got on a GLP-1 and no other medication but one oral medication, my whole disposition basically changed because I was happy I didn't have to take these needles every day. I was happy that I did lose a little bit of weight, but I'm not going to say that, okay, this is a good one for your diet. No, but I did lose some pounds. So with the GLP-1, and that's all I was doing with one oral medication, my numbers have never been above 130. And like I said, 130 is high. And like I said, when it goes to 140, it's something I did. It has nothing to do with anything else. I could recognize that now.
Thank you for those insights, Mrs. Schultz. Are there any contraindications to using GLP-1 receptor agonists? The labels contraindicate their use in patients with personal or family history of medullary thyroid cancer or multiple endocrine neoplasia, which are extremely rare. This is based on rat data without human signal for risk. GLP-1 receptor agonists also have not been well studied in patients with chronic pancreatitis or gastroparesis, which may impact choice of therapy. There are a few clinical scenarios that impact the guidance we provide to patients. If a patient has diabetic retinopathy, it is important that they keep their routine ophthalmology exams, as the high glycemic efficacy of these medications may contribute to early worsening of the retinopathy. Patients should be counseled on signs and symptoms of pancreatitis as well as gallbladder disease. And for those with renal impairment, significant gastrointestinal intolerability such as nausea and dehydration should prompt closer renal monitoring and assessment. It is important to recognize potential barriers, particularly early in the treatment course. Patients should be provided with anticipatory guidance to help minimize any gastrointestinal intolerability. We typically counsel patients that it is okay to eat smaller meals and eat less high-fat foods, to stop eating when they feel full, and to be mindful of eating patterns and responses. Nausea, when it occurs, is typically transient during the initiation and escalation phases and typically dissipates within the first few weeks. Dosing flexibility, such as slower titration, may help. Finally, for many, earlier satiety may actually be a new sensation, and this should be embraced. Eating beyond this level of satiety may contribute to nausea. Thus, education of the mechanism of action of GLP-1 receptor agonists is key. When patients are empowered with this information, they are more likely to succeed with therapy. Now let's hear again from our patient on her experience with GLP-1 receptor agonist therapy.
Kind of controlled my appetite. I felt full quicker. So I didn't have to eat as much or as often, although, they want you to eat 3 meals and 3 snacks. I mean, who really do that? That's just was too much, but it helped me there. Right now, I think I'm good. I'm not going to say excellent. That means I won't have no place to go. That's what my teachers used to tell me when they wouldn't give me an A. If I give you an A first semester, you wouldn't have nothing to reach. So I'm doing good. I think what I had to overcome more than anything is the fear of what people with diabetes was trying to let me know. Oh, you're going to lose a limb. You're going to, you're going to lose your hair. I mean, just crazy stuff.
Let me summarize by putting all of this together in a patient-centric clinical construct and example conversation, beginning with patient-centered physiology. I usually explain to patients as follows. GLP-1 receptor agonists help your body sense and respond to glucose, reduce appetite, support weight loss, and reduce the risk of heart complications. I follow this with reviewing our clinical care goals and how GLP-1 receptor agonists fit. For example, our goals are to achieve and maintain glycemic control safely while continuing to address weight and supporting long-term health by reducing your risk of complications. Finally, I find it's important to provide anticipatory guidance for success. Here's an example. You may feel fuller sooner, be less hungry, and lose weight. Embrace the positive. Nausea, if it occurs, usually lessens with time. Call your provider if you're having abdominal pain or severe effects. Let's hear again from our patient.
The first thing I would tell them is what she told me. It does not take the place of your insulin. And then I would tell them, it didn't take the place of my insulin, but it got me off of insulin. And it has kept me off of insulin. And it made me feel as though it wasn't a death threat. You don't have to walk around with the icing package in your pocketbook because your sugar might fall. Or it's not a death threat. And it was the best thing that happened.
To conclude, we have covered many aspects of GLP-1 receptor agonists and their role in the treatment of type 2 diabetes. Let me summarize some points here. GLP-1 receptor agonists have important glycemic and non-glycemic effects. They can be used by most patients with type 2 diabetes and are well tolerated. As an example, some agents in this class can be used by patients across the full spectrum of renal function. When individualized appropriately, they are especially beneficial for patients who meet any of the following: patients who are not at their glycemic goal given their high glycemic efficacy, patients with established atherosclerotic cardiovascular disease or at high risk of cardiovascular events, patients who would benefit from weight loss, patients who have a compelling need to avoid hypoglycemia, patients with chronic kidney disease, and it's important to remember that all patients should be provided with clear anticipatory guidance about the medication's likely effects and clear criteria for when to call their provider. That ends our discussion for today. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KMJ860. This activity is supported by an educational grant from Novo Nordisk Incorporated. This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.